Good morning.
Foundation Dr. Julien, and especially to organizer the opportunity to be here and to share with this audience how to improve quality of life in children. Well, first of all, just looking, thinking who you said that why I was thinking about why when I was surprised looking at the program when my presentation will be shared with the presentation on rights on child health, and then I was thinking that our research area, what I'm trying to do is trying to get the voice to children. Okay, I would try to approach, first of all, what quality of life and health-related quality of life conceptually is, how a health-related quality of life instrument that I will try to approach can be selected on how to measure and to interpret the results, with one example using the instrument called KidScreen. How to assess social inequalities in child health by using this outcome measure, and how to assess the impact of social interventions with some examples, and then some remarks and conclusions. Well, as the starting point, conceptually, health-related quality of life is defined as subjective perceived health, according to the World Health Organization definition. It is a multidimensional construct that includes well-being, functioning as perceived by individuals themselves. This is very important to know previously. And currently is widely used in different areas, the assessment of health-related quality of life, to describe well-being of the general population and to identify risk groups, in clinical and social research to evaluate interventions and treatment effects, and also in routine clinical practice, and in health economics to compare treatment cost and to try to allocate resources. Well, there are several genetic and disease-specific instruments available for adult and lower number of instruments for children. And one aspect, first of all, that I would like to tell you is that the assessment in pediatric area, different from adult area, should include several aspects such as family functioning, relationship with peers, community factors, and all these factors contribute to health-related quality of life and mediate the impact of disease and treatment on child health. Currently, there are more than 100 instruments, standardized instruments, addressed to assess health-related quality of life in children. And looking at the content of dimension and items, for example, this is an example of 9 instruments, and looking at the content in terms of physical, psychological, and social aspects, you can see that these instruments have a great variability in terms of the proportion of items addressed to each one of these main aspects of health, according to the WHO definition. And one aspect that methodologically is very important and is one difference from adult assessment is at which age children are able to validly and reliably answer a questionnaire. And this is an example. This is a figure from a seminal study with the development of the Child Health and Illness Profile Child Edition, from the United States that more than 10 years ago, they carried out interview with more than 100 of children to look if they understand abstract concepts to try to be included in the instrument. The interviews were carried out with children 5 to 11 years old, and the CHIP CE is addressed to children 6 to 11 years. And then when they carried out this interview, for example, children 5 years old did not understand abstract concepts such as irritability, for example. At 6 years, they were able to respond and to understand some concepts, and from 8 years onward, they were able to answer any questionnaires with abstract concepts related to health and without memory bias and as reliable as and valid as any other instruments. In terms of practical rules, we can say that looking at the diverse instruments and the ages at which are addressed, that from 6 years onward, we can administer a questionnaire with the help of an interviewer. And self-administered questionnaire can be used from 8 years onward. Even we know that cognitive development is really very variable at certain ages. And well, it can be recommended that previous to the administration should be assessed cognitive development of each child in ages at the limit of age, these ages that I mentioned. Sorry. And the next question is how to measure health-related quality of life in children younger than 6 years old. And then we use informed and reported outcomes, but informed and reported measure should be observable content as much as possible. Some guides on the development of patient-reported outcomes in younger children states that observer reports include only those aspects or behaviors that can be observed and are reproducible and administered in a standardized way. For example, observers cannot validly assess infants' pain intensity, but they can collect and assess some behaviors thought to be caused by pain. No? In this example, you can see the development, the process of development of a standardized instrument to assess nausea in infants and younger children. And these instruments should be standardized in a reliable and valid way, similar way than self-reported measures. Well, and how an instrument can be selected and interpreted. Well, one simple way is, first of all, we should look at what is the main purpose of the study or why we are trying to measure quality of life. One important thing is that the instrument we select should match the expected outcomes with the dimensions or items of the instrument. Another question is that it should be, the dimensions of the instrument should be relevant for the study proposal. And of course, if it's available for age group of interest. And when there is more than one instrument to select, one aspect that should be taken into account is the measurement properties of the instrument. This is a summary of the properties that all instruments should fulfill according to the recommendation of the Scientific Committee of the Medical Outcome Trust. First of all, conceptual and measurement model, that more or less is what I was talking about now. Then reliability and validity. Responsiveness is one of the important things, mainly today if we are talking about trying to assess changes with one intervention. The instrument should be sensitive to changes in health if we carried out one intervention. Another aspects are responding an administrative burden, alternative forms, and also it is important that the instrument is culturally and language adapted to the population we are analyzing. One of the worldwide used instrument is called the kit screen. The kit screen was developed simultaneously in 13 European countries, and well, according to classical and modern psychometric theory, there is a set of instruments from kit screen. I don't know if you could see all the. There are three main versions and addressed to self-reported and parent-reported versions, each instrument. The larger version is a 52-item version with 10 dimensions of health, and intermediate versions mainly proposed to be used in clinical practice with 5 dimensions that exclude only bullying, social acceptance from the larger version. And then an index, the kit screen 10, that is an index that include all dimensions or try to capture all dimensions of the kit screen 27. Well, most instruments, the majority of instruments, psychometric instruments, are scored in a 0 to 100 score. In this figure, you can see the distribution of hypothetical distribution of a dimension in the study population. And in this case, scale 0-100 means that higher score is better health. But in any case, if you don't know anything about psychometrics, one score on their own doesn't mean anything if it's not related to a context. For example, comparing with the same age and sex or similar age and sex in the population. In this sense, I think that an improvement is, for example, I'm talking about the experience with kit screen. For example, if kit screen collected a representative population of 13 European countries with more than 22,000 children and adolescents, and then we collected the reference population values. That means standardizing the score to a mean of 50 and one standard deviation of 10, you can compare your study population with this population, saying that if the score is higher than 50, it's better than the population, than the average population. And if it is lower than 50, it's worse than the average population. And according to several studies on health-related quality of life, it is conventionally accepted that when the score is 0.2 standard deviation lower, is the minimal important difference that is clinically detectable. Half a standard deviation is moderate difference, and 0.8 standard deviation is great difference. Well, and now examples on how to assess social inequalities in child health. I would like to present this because it's one of the best seminal studies carried out by Barbara Starfield. In this case, I presented a profile using the child health and illness profile, adolescent edition, according to social class, 2 profiles, the best profile and the poorest profile, and you can see a gradient between social classes, advantages social classes and disadvantages social classes, a gradient between them with, in both cases, the odds ratio was 1.72 and 1.88. Okay, and by using the kit screen, maybe easy to understand, as I explained, that looking at the average population of 50, And the Spanish kids screen sample, stratified by family affluence scale, that is a proxy measure of income, family income, no? In 3 categories. You can see also a gradient with the wealthiest families, higher score in almost all dimensions of the kids screen, and with higher differences in economic resources as expected. Well, another example is the kids screen index, kids screen 10, that was used in the health behavior in school-age children, an international study, and in this case also analyzed according to the family affluence scale in 15 countries. And you can see that the kids screen index capture a gradient in almost all 15 countries according to family affluence scale. And another example in this case is by using the kids screen 10 parent version, the proxy version, in the Catalan Health Interview Survey. There were the last 2 surveys were in 2006 and 2012, and allowed us to analyze the impact of economic crisis in Catalonia in a before-after approach. And you can see here that in this case is the index in 0 to 100 score. You can see that in the second survey, that in 2012, the average score was higher, was better than the previous score. But looking at differences according to the highest family levels of education, children of families with primary education improved less than the rest of groups. That means that social inequalities appeared during the study period. And how to assess specifically social interventions. Let me show you a couple of examples on this. This is an example by using the vécu ex ante perçu de l'adolescent that was developed in Marseille, France. And 10 years ago, when in Catalonia we received a lot of young immigrants, mainly from Iberoamerica and Africa, managers and pediatricians from Costa Brava, the place in Catalonia, asked us if there were inequalities in perceived health, if they needed to start any specific program addressed to this population. And you can see here the index of BESPA score, the vécu ex ante perçu de l'adolescent, that is normal distribution. Participated 2 schools in Lloret de Mar in Spain, with was 1,200 adolescents. As expected, girls showed lower scores than boys. Younger children, higher score, better scores than older children, and natives, better score than immigrants, without differences according to the area of origin. Then we carried out a multiple linear regression model, and when immigrant was included, the coefficient was negative. That means that diminished the BESPA index score, the quality of life index, statistically significant score. Then when we introduced age, sex, and socioeconomic status, the family affluence scale, all these factors were statistically significant, and immigrant coefficient still remained significant. And when we included psychological stress, bullying, and discrimination, all these were really statistically significant with higher score, negative score, and immigrant disappeared from the model. And then, as a conclusion, we recommended to pediatricians and managers to start a program looking at addressing mainly discrimination and bullying to this population to try to improve and to diminish inequalities in quality of life. Another example came from Sweden. This is a paper that was published relatively recently. Some people from Sweden, some colleagues, were interested in knowing when they receive young immigrants, the policy in Sweden is to try to distribute them homogeneously. And then they were interested in knowing if health-related quality of life at individual level were different or similar when young immigrants come to a place where families are from migrant origin in less than 10%, so really few families at the school level, or half of the population in this school level are from migrant origin, or higher than this. And then this is the result, the percentage of children that perceived bullying according to the percentage of family at the school level. And you can see that both in boys and girls, when less than 10% of the school population are families from migrant origin, the percentage of bullying is higher. That means that the authorities should try to look at this policy and try to modify or try to implement some intervention to try to diminish this kind of results. And the last example is by using health-related quality of life in clinical practice. It's quite different, but I wanted to show you that now we developed the kit screen, the informatic version, and we administer the kit screen, in this case the kit screen 27, via internet at home, and then this result, like this figure, is shared and commented during the clinical visits. And then if the dimensions are at the average or higher, doesn't matter, but when the one dimension, like school, is lower than this, this is commented and some changes are trying to propose. And now we are using this in a group of children with type 1 diabetes, using in an intervention group, and compare this after 1 year with the control group that used usual practice. Well, health-related quality of life measurement was improved in the last year, and are really of interest in epidemiology, in healthcare, in social services. Before selecting one instrument, it's important to know why to use this measure and to try to match the dimensions with the purpose of the study. Assessment of self-reported questionnaire is as long as possible, and the development of observer-reported measure would be necessary in specific situations. I can try to explain that maybe health-related quality of life measure is really improving, but as you can see, the instrument have a specific range of scores, and I know that for example, the perceived health is really very rich, it's infinite. This is a dilemma probably when we are looking at qualitative versus quantitative studies. No? Maybe mixed methods could be a solution to solve these questions or these limitations. And health-related quality of life is an appropriate outcome measure to evaluate social inequalities and to assess children's living conditions and the impact of healthcare interventions. Thank you.